It's a powerful statement. Our next speaker is Dr. Joseph Bocchini, who will be addressing safe and effective HPV vaccine, the pediatrician's critical role. Dr. Bocchini is a past chairperson of the AAP Committee on Infectious Disease. He also is a past member of the Advisory Committee on Immunization Practices of the Centers for Disease Control and Prevention, during which time he chaired the ACIP work group for HPV vaccine. And he continues to serve as a member of the ACIP HPV work group. Dr. Bocchini is professor and chairman of pediatrics of the Department of Pediatrics at Louisiana State University Health Sciences Center in Shreveport, Louisiana, where he also serves as medical director of the Children's Hospital. Please welcome Dr. Bocchini.
Good morning. I want to thank the Planning Committee for giving me this opportunity to talk about HPV vaccine. And I'm going to use this opportunity to present a challenge to you all. We have 3 vaccines that are recommended for pre-adolescents at age 11 to 12. For Tdap and meningococcal conjugate vaccine, we have achieved the Healthy People 2020 goal of immunizing over 80% of our children, and actually by age 17. Unfortunately, for HPV vaccine, which is also recommended for this age group, we are way behind. So my challenge is that based on the information that is available about the safety and effectiveness of HPV vaccine, that we need to look in our own practices to determine what we need to do to bring that level up to 80% or better as soon as possible, because we are the only individuals as pediatricians who have the opportunity to protect our patients before they become exposed to this virus, which is an important cause of cancer in the United States and around the world. As you know, human papillomavirus is the most common sexually transmitted infection in the United States. Any sexual contact, any intimate mucous membrane to skin contact can be associated with transmission of HPV viruses. There are over 40 of them. 13 of them are high-risk viruses that can produce cancer. Most infections are undetected. They're asymptomatic. However, persistent infection is responsible for cervical, vaginal, vulvar, penile, anal, and oropharyngeal cancers, and a number of precancerous lesions, which are the basis of our successful PAAP testing program, by removing tissue that has become dysplastic because of HPV infection prior to the development of cancer. HPV also causes genital warts. In the United States, over 31,000 HPV-related cancers are reported each year. The burden of cancer is somewhat higher in women, but as you can see, there's a significant burden of cancer in both men and women in the United States. The most common cancer in men is oropharyngeal, and the rate of oropharyngeal cancer is increasing at such an annual increase rate that it is potentially going to exceed the number of cases of cervical cancer by the year 2020. This slide shows data from the National Health and Nutrition Examination Survey that was done in the years 2003, 2006, prior to the introduction of HPV vaccine. You can see circled here that 14 to 19-year-old girls who did a self-obtained cervical vaginal swab, over 20% of them were colonized with a high-risk type of HPV. So by 19 years of age, there is a colonization rate, at least on one site, of over 20%. We have 3 HPV vaccines. The first was licensed in the United States 10 years ago. All 3 of the vaccines contain HPV types 16 and 18, which are responsible for approximately 70 to 80% of cancers related to HPV. And the 9-valent Gardasil vaccine also contains, in addition to those 2 types, 5 additional serotypes that are responsible for an additional 14% of cancers in women and 5% of cancers in men. So these vaccines, especially the 9-valent vaccine, can prevent over 90% of HPV-related cancers. Now, the bivalent vaccine, Cervarix, the manufacturer has decided to no longer distribute this vaccine in the United States. Stocks will be depleted by November, so this vaccine will no longer be available. The quadrivalent vaccine, Merck will no longer distribute this vaccine as of the end of this month, and therefore we have one available HPV vaccine going forward, and that's the 9-valent vaccine. The important thing I want to also mention today is that less than a week ago, the ACIP voted, based on data that I will show you in a couple of slides, to introduce a 2-dose schedule for the 9-valent vaccine for boys and girls less than 15 years of age. So we now have an opportunity to improve our completion rate with a 2-dose vaccine series, with the recommendation being that the second dose is given 6 to 12 months after the first dose. And I'll show you the data that supports that decision in the next couple of slides. The 2-dose trials were done by the manufacturer. They compared 9 to 14-year-old boys and girls given 2 doses at 0 and 6 months and 0 at 12 months to 9 to 14-year-old girls who received the 3-dose series and 16 to 26-year-old women who received the standard 3-dose series at 0, 2, and 6 months of age. 97.9% to 100% response rate was seen in all vaccine recipients to all types of HPV included in the 9-valent vaccine. And geometric mean titers were met, the non-inferiority criteria were met for all of the 9 serotypes or 9 types. And as seen in the 4-valent vaccine trials and the earlier trials with 3 doses with 9-valent HPV, the geometric mean titers were higher at 1 month after the last dose in the 2-dose series for 9 to 14-year-olds than was seen in the 16 to 26-year-old women who received the 3-dose regimen. And again, these women are protected based on the levels that we see and the results of the clinical trials that show protection against HPV. So by immunobridging, it's very clear that the serologic results favor a 2-dose schedule. So last Wednesday, the ACIP, actually on October 7th, the FDA extended the license of the HPV-9 vaccine to include the 2-dose series. On Wednesday of last week, the ACIP voted to approve the 2-dose series. So going forward, the routine recommendation will be a 2-dose regimen beginning at 11 to 12. We can start immunizing as early as 9 years of age, and we can use the 2-dose regimen for all 19 through 14-year-old children. The second dose is given 6 or 12 months, or 6 to 12 months after the first dose. This recommendation was approved by the ACIP. It was approved by the director of the CDC. It will become official when it is published in the MMWR, which will hopefully be a note that is published within the next 2 to 4 weeks. The Committee on Infectious Diseases of the American Academy of Pediatrics participated in the decision and will provide a policy note, which again, this will become official AAP policy when the note is published in Pediatrics, may be published electronically on Redbook online. The 3-dose regimen will still need to be given for 9 to 14-year-olds who have already received 2 doses where the second dose was given less than 5 months prior to the first, or for individuals who initiate their vaccine series at 15 years of age or older. And anyone who's immunocompromised at any age that's within the age range for giving the vaccine should also receive a 3-dose series. Now, I just want to review a few things that show how effective the HPV vaccine has been. Within 10 years, around the world, there have been a number of studies that have shown significant population impact for the incidence of HPV vaccine type prevalence. There's been significant reduction of the 4 types that are in the 4-valent vaccine, as well as the same 2 types in the 2-valent vaccine in multiple countries. There's been a significant reduction in genital warts in multiple countries, and we're beginning to see changes in the incidence of cervical intraepithelial neoplasia caused by the types that are in the vaccine. So we now see in multiple countries, including the United States, a significant population impact on both the prevalence and now the early dysplastic changes that are associated with HPV. As you know, it takes up to 20 years before a patient who's infected with a persistent infection with an oncogenic type of HPV will develop a precancerous or cancerous lesion. Now, I want to just highlight one study from the United States. This is, again, an NHANES study. This is comparing the data I showed you for 2003 to 2006 versus the time period of 2009 through 2012. And again, it's self-obtained cervical vaginal swabs from women participating in this study. And you can see that in 14 and 19-year-olds, there's been a decrease, a 64% decrease in prevalence of the 4 types that are in the quadrivalent vaccine, and a 34% decrease in the 4 types in the vaccine in 20 to 24-year-olds, both of which would be groups that would be targeted for vaccination, and no change in the group that's 25 years of age and older as expected. Looking specifically at 16 and 18, there was a 60% reduction in prevalence. And looking at patients who were vaccinated versus unvaccinated, it looked like with at least 1 or more doses of vaccine that there was almost a 90% vaccine effectiveness in preventing infection with one of these 4 types. There was no change in the incidence of the 5 oncogenic types that are now in the 9-valent vaccine, which would be expected if there was no cross-protection provided by the 4 types in the vaccine. But it also gives us preliminary evidence that there may not be strain replacement with the use of the HPV vaccine or type replacement. Now, in terms of safety, there have been over 79 million doses of 4-valent HPV vaccine and now 12 million doses of 9-valent vaccine distributed in the United States. In all of the post-licensure monitoring systems that we have in the United States, there has not been any significant new safety issue that has been found related to HPV vaccine. The institutes and actually the pregnancy registries that were established for both the 2 and 4-valent vaccines have now been closed by the FDA because there has been no safety issue identified related to the receipt of these vaccines if given inadvertently to a pregnant woman. The Institute of Medicine report on HPV vaccine safety, which was published a few years ago, found the only new adverse event was the relationship of injection, not specifically vaccine, but injection with syncope, which we're all well aware of, and the possibility of anaphylaxis, but at a very low rate of 1 in a million doses. The CDC's Vaccine Safety Data Link system looked at over 600,000 doses of HPV vaccine and identified no association with any of the conditions that were initially concerned or raised as concerns with the use of the 4-valent vaccine. And more recently, the Global Advisory Committee on Vaccine Safety looked at the more recent allegations of syndromes or conditions associated with HPV vaccine and found that there was evidence against these associations or no evidence to support an association with the presence of aluminum adjuvant, Guillain-Barré syndrome, multiple sclerosis, any autoimmune disease, and these rarer events that people have been talking about on the internet, such as primary ovarian failure, complex regional pain syndrome, and postural orthostatic tachycardia syndrome. So why do we have the discrepancy? This is data from the National Immunization Survey Teen, which goes back to 2006 and reports data now through 2015. And you can see that in children 13 to 17 years of age, females, only 62.8% have initiated the HPV vaccine series, and only 41.9% have completed it. For males, it's even lower rate, 49.8% have begun the series, 28.1% have completed it. So there's no question that this vaccine is being considered differently than the other two vaccines that are here on this slide, Tdap and conjugate meningococcal quadrivalent vaccine. I think that there are a number of evidence-based messages that have been proven to be important in increasing rates of HPV vaccine acceptance. First, parents should understand and realize that HPV vaccine is cancer prevention. This is a vaccine that is designed to prevent cancers related to oncogenic types of HPV. Parents need to understand it's best to give this vaccine at 11 to 12 or even earlier, as early as age 9. We have an opportunity to give the vaccine before a child gets exposed to HPV. We need to take that opportunity. And we want to recognize the importance of getting all recommended doses on schedule so that we can complete the series. And now with the new recommendation for children who initiate the series at below age 15, we now have a better opportunity to complete a 2-dose series than potentially a 3-dose series. And for us as providers, it's important that we can answer questions that parents may have about HPV vaccine by being familiar with the epidemiology of HPV infection, the outcomes of infection, and the indications for giving the vaccine. Understand that the vaccine is valued. There is data that shows that pediatricians think that HPV vaccine is less valued than other vaccines, and yet the same study shows that parents value HPV vaccine as much as they do the other vaccines that we recommend. We need to make a strong recommendation. One of the things that's really important is not to make HPV vaccine a vaccine that's given with a recommendation that's not as strong as the other vaccines we're giving. We need to bundle the recommendation. Research has shown that if we initiate a discussion with a parent of an 11 to 12-year-old and say that today your child needs 3 vaccines. They need meningococcal conjugate vaccine to prevent meningitis, they need HPV vaccine to prevent cancer, and they need Tdap to boost their immunity to protect them against diphtheria, tetanus, and pertussis. It resonates well with parents, and for many parents, that's all they need. You've made a strong recommendation for HPV as you have for the other vaccines that are given at that age. And when parents ask questions, don't assume that they are reluctant or hesitant. They may be just asking questions to get their concerns answered, and once you answer them, would be willing to have their children immunized. There are a number of evidence-based messages that show you that how you can improve office performance. You're very familiar with all of these. You want to make every visit a vaccine visit, harmonize messages amongst all of the individuals who work in your office, and you can use a number of things to try and improve the immunization rate in your offices. The important thing is that each of these is statistically significantly associated with an increase in immunization rates, but none of them get you up to 80%. The important thing to get you up to 80% is provider commitment. The strongest reason, or the most important reason, that a parent will choose to have their child vaccinated is your strong recommendation. Use the fact that parents trust you and accept your recommendations to make HPV vaccine rates go up to where we need to as quickly as possible. Both the CDC and the AAP recognize the importance of some of the the issues, the barriers that have resulted in the delay in uptake of HPV vaccine, and have created a number of resources for you to help you get information, hone your message, and provide information to parents who may need additional information to make a decision. You can go to the CDC website for that information. The AAP has a number of resources as well, and even a QI program that can help you improve adolescent immunization rates, and even has a HPV champion toolkit that you can use to improve office performance and improve immunization rates. So my key points are HPV-related cancers are common. Vaccines are designed to prevent cancer. And the vaccines that we now have a 10-year history of the use of these vaccines, it's very clear that they're safe, and we have now increasing evidence of how effective they are. Your role is critical. You're the only individual or individuals who have the opportunity to give this vaccine prior to a child being exposed to HPV. And the 2-dose regimen for those less than 15 years of age will become the standard recommendation probably within the next 2 to 4 weeks. Thank you for your attention.